delighted to say that once again for one of our Top Doctor podcast interviews, I'm joined today by highly esteemed duo, the two consultant orthopaedic surgeons from the specialist spine unit, Mr. Colin Natali and Mr. Ramsey Chammaa. So, Mr. Natali and Mr. Chammaa, if you maybe want to tell the viewers maybe about your background, your career so far.
Okay, I'll start because I'm the oldest. Sure. So I'm a consultant orthopedic surgeon, and but I only do spinal surgery. I did my fellowship in Australia, and then came and took up a post at the Royal London Hospital. And since then, I've been doing spinal surgery solely. So I don't do hips, I don't do knees. Ramsey?
So yeah, I am also an orthopedic surgeon. I trained at the Royal London, so Mr. Natali was my boss back in the day. I completed my training and then did a fellowship at the Royal London and Great Ormond Street, and then another fellowship in New Zealand for a year. I've been a consultant since 2019 at the Whittington, where I'm also the clinical lead. So I do general trauma as part of my own calls, but my elective practice is adult, degenerative, spinal surgery, and then I've been working at the Princess Grace now for over a year.
Fantastic. Plenty of experience, and it's fantastic to get your insights today with regards to recent advancements in spinal surgery, particularly. So the first question that we wanted to ask you both, what are some of the recent advancements in terms of technological advancements in spinal surgery, and how do they differ from the more traditional methods?
Okay, shall I have a go at that first of all? I think the first thing is, one of the things we're here at is the specialist spine unit. So what we have is we have spinal surgeons, we have rheumatologists, pain management consultants, we have a spinal specialist nurse, we have the whole team, including all the clerical staff that run everything for us. And what that does is that frees us up to do patient care. And it's not just about spinal surgery, it's about everything from start to finish. The time you get back pain, whether you have an interaction with your GP, your pharmacist, we link very strongly with physical therapists. And I use the word physical therapist advisedly because there's physios, osteos, chiro, acupuncture, all manner of therapists. And we also liaise with occupational health people, so we deal with workplace issues. And we can take the whole gamut of patients from the very first time you get back pain and just reach for your paracetamol, all the way to a small group of patients that have surgery or need surgery. Ramsey?
No, agreed. I think it's really appreciating the holistic approach to a patient. So most conditions can be treated non-operatively, and I think there's a lot of anxiety that comes with new pain, or particularly if you've had a scan and then you use Dr. Google, which is always a bad thing.
Yes.
And you look at all these pathological conditions mentioned in a report, which to us, because it's our day job, much of that is physiological. So if I put many people in the same age group through a scan, you'll find similar findings. So in their own merits, they're not concerning, but it's just a way of breaking things down, removing some of that anxiety, better patient education, which means that most conditions can be treated through conservative measures, and then surgery and more interventional things are reserved in cases of emergency or symptoms that persist.
Yeah, I'll second that. See, Dr. Google is fine, but we get patients who come in and they have some numbness because they've got a prolapsed disc in their neck, and they've been around the houses and they think they've got multiple sclerosis because that's what Google tells them.
Exactly.
And it's unexpurgated. You cannot control the inflow of information through Dr. Google or Dr. Bing. And part of the reason we liaise with physios, chiros, osteopaths, with GPs, pharmacists, and everybody is because it's about getting a diagnosis early and then sorting it out. Because anxiety is the worst thing you need when you've got a condition.
Absolutely.
So that's one of the things that we really take exception and try to foster really quickly. We're here to help patients to do no harm and not to dive in unnecessarily.
Absolutely, Mr. Natali and Mr. Chammaa, fantastic insights there into recent advancements. And I'm happy to say, actually, we have another doctor to join us. Anwar is going to join us, which is great. Maybe he can offer some of his insights as well into this question that you both answered, which would be fantastic.
Hanny, welcome, Hanny. You're on mute.
Hello.
Yeah.
Hello, Mr. Anwar. Fantastic.
Hello. Hi. How are you doing? You guys all right?
Absolutely perfect. Thanks for joining. Great to have you.
Yeah, good to see you too. Good to see you too. How about Colin, Ramsey? You guys all right?
Very good, very
Really
good.
well.
Great to see you.
In a lovely room with big windows, seeing the sun.
Oh,
Great, great. That's a novelty. Is that how you roll all the time at PG?
Yeah,
Always.
we have the sun here all the time. We just Andy, what we've done is we've just done a discussion of about team working and what we do, and then we'll go into things like recent advances and some of the advances.
Okay.
So I've just slagged off Dr. Google because the patients you get where they've got D6 numbness and they think they've got MS.
Okay. Yeah.
That's the first thing that comes up when you say I've got numbness, or may have multiple sclerosis.
Yeah. I mean, I think most of them have multiple sclerosis as well.
Either that or some nasty cancer.
We're not
exactly.
recorded, right?
Yeah. So what are we actually doing over the next?
So did you get a list of questions, Harry?
oh yes.
Probably.
So
Did you read them?
6
No.
questions.
Probably not.
6 questions.
All right.
Yeah, of course I read them. As if I would not read that.
Oh yeah, he was last night checking the answers, questions.
So
Yeah.
the first one, Harry, was what are the most recent advances in spinal surgical techniques and how are they different from conventional surgery? That was the first question. So we've just gone into T. So because you've got quite a niche market in what you do, so you need to have a window to speak. So Connor, if you want to ask the most recent advances, if I do some bit about early stuff, Ramsey can do a little bit more about some of the stuff he does, and then Hannah, you can do your robotics and navigation.
Excellent. That would work really well. Absolutely.
Okay, John, ask the question then, Connor.
Perfect stuff, so guys. So yes, delighted to say we're joined now by all 3 of you guys, Mr. Colin Natali, Mr. Ramsey Chammaa, and Mr. Anwar. So it's fantastic to get your expert analysis. And we touched on question 1 a little bit, but maybe if we touch on it again, so we can have everybody delving in. So what are some of the most recent advancements in spinal surgery techniques, and how do they differ from conventional methods in the past?
Okay, so shall I go first again, just because I'm the oldest?
Yeah.
So one of the things that is really outstanding is the fact that we've gone away from this, if you lift something, you're going to hurt yourself. If you're sitting at a desk all day, you're going to hurt yourself. There's really bad evidence about occupational pain, back and neck pain. We're fed information if we're using our phone, we're going to do bad things. It's all about activity. It's maintaining levels of activity that's probably more important than having an ergonomic chair and a sit-stand desk. They're comfortable and people are making a lot of money. But what we want people to do is maintain activity. And any intervention we do is aimed at getting people back to living normally. That's the whole aim of doing it. Medicine do no harm. So you don't want to dive in and do something that's going to make patients worse off. But on top of that, anything you do has got to be cost effective. Because again, you don't want people going in and spending lots of money and doing things that don't make any money. And we are always courted by pharmaceutical companies, by surgical companies telling us how wonderful things are. And most of those wonderful things involve price. So we're sort of the gatekeepers of finding out what's reasonable and doing good stuff and making sure that our patients do well. So I'll take one of the first bits about what's different. So it's early treatment. So it's the preoperative preparation for planning, doing surgery and for discharging. We use this thing called ERAS, which is early recovery after spine surgery, where we optimize people before with their information. We can optimize their nutritional status. We can optimize the anesthetic you can do and have post-operative analgesics. So whatever you do to them, they get better faster. That makes a difference to patient outcomes and length of stay in hospitals. So Ramsey, do you want to talk about minimally invasive stuff?
Yeah, sure. So obviously there are new techniques through the advent of microscopes having gone through loops, smaller incisions, tubular and endoscopic surgery. It all sort of offers less destruction to tissues, less blood loss, less opiates requirements, shorter hospital stay, and hopefully with comparable outcomes. Like anything, a new technique has a learning curve. So when you're moving from a more traditional operation, I think rather than focusing on something that's minimally invasive, the most important thing is having a surgeon who's appropriately trained and who's competent with good outcomes. And I think that that's more important.
So going back to that, so it's about doing the right operation, using the right instruments. And Hanny's got a great deal of experience with navigation and robotics. So Hanny, would you like to talk about that?
Yeah, sure. So the spine is very complex anatomy. You've got multiple bones which have joints between them, and you've got the spinal cord, and you've got nerve roots which come out at each level in the spine, going off and doing different things. And you've also got big blood vessels just sitting in front of the spinal cord and sometimes going around the the spinal column, the vertebral column. And you've also got other organs which are closely associated with the spine. So all of this means that, understandably, surgeons want to see a lot in order to be able to operate on the spine, because you don't want to accidentally injure something which would be harmful to the patient. But these things like navigation and robotics, they make a big difference these days, because it allows you to see things that you otherwise wouldn't be able to see. Where are the nerves sitting exactly? Where exactly is the spinal canal and the spinal cord? And it'll give you some information. Now we're merging MRI and CT. We can do soft tissue navigation. We can also actually put the implants if we're putting implants into the spine, into the navigation system or the robotic system, see how everything will line up. If we're doing a deformity correction, change the shape of the spine on the software before we actually change the shape of the spine in a patient. So we see how it's going to look afterwards and make sure that it looks like we want it to look, and we achieve what we want to achieve. So this kind of technology now, it makes us able to be accurate and precise, to be less invasive, because we can see things that we might not otherwise be able to see without making a very big hole. And we can also start to kind of predict what we're going to achieve before we actually have to go ahead and do the operation. So it really makes a big difference.
There's two words that we throw around a lot. That's navigation and robotics. And for those people that are listening, what navigation is like Google Maps. So you're in your car, it tells you where you should be going, but you can ignore it.
Oh.
So it tells you which road you could take, but you don't have to follow it. So you can take your alternative route. Navigation will tell you where you should be going. Robotics is like a self-drive car. It takes you there. And it's complex kit, it's expensive kit, it needs training, but it works extremely well because it gets you into a safe window. Hence what Hanny was saying about you can predict what you've got. And we are now merging soft tissue and bony anatomy. So you can actually, for tumours, which is Hanny's, one of the big things that Hanny does, you can see where the tumour is. You can see where it extends to in real time as you're looking at stuff. And if you're looking at big breakthroughs, that is one of the big breakthroughs. It has a cost associated with it because of the cost of the equipment. And there is a learning curve. And there can be time delays. It can take longer to do an operation. But if you're a patient, you'd want safety above everything else. You don't care how long it takes, you want safety. Because modern anaesthetics are extremely safe.
Fantastic, everybody. Really, really. And the insight is fantastic. And for patients who might be a little bit nervous or unsure about the benefits, how long would a consultation be for them to maybe explain the benefits?
So I'll rephrase that. So you mean a consultation with a patient?
Absolutely, with the patient, absolutely.
So they all vary, So I'll give you an example. If a patient comes in, so they're having half an hour slot. You do half an hour, don't you, Hanny?
Yeah.
Yeah, and you do.
I do as well.
So they have half an hour slot. If somebody comes in and says, I've got neck pain and I've got numbness in my index and ring and my thumb, index finger and thumb, that's a C5-6 prolapsed intervertebral disc. You say, yep, you've got a C5-6 prolapsed intervertebral disc, most likely. I'm going to send you for an MRI scan. That takes 2 minutes. And so patients go, but I want to tell you a bit more. We've got the diagnosis very quickly. But if they have a really complex history, they can take as long as they want. That's one of the most important things. You shouldn't go out and feel as though you haven't answered or asked all of the things you wanted to do. I encourage patients everyone's got a mobile phone. I encourage them to make notes, and they come in with notes. Sometimes there's lots of notes. Sometimes there's not, there's only a few notes, but they get as long as they want. Because if you were a patient, that's what you'd want. You wouldn't want somebody looking at their watch and saying, time's up. So they get as long as they want.
Absolutely, the reassurance. Yeah.
I think, yeah, it's all about the patient journey. So you also support their education and learning through leaflets as well. So they can scan a QR code to learn about something and read about something in their own time, which supports what you've discussed in a clinic consultation. They might not always take everything on board, but then when you dictate a letter, it's all there for them to sort of reread again. So I think it is important that, as Colin says, you don't rush them, you try and answer all their questions. And it is a continuum. So you'll see them at the beginning, and if you plan for surgery, you'll see them closer to the time, maybe to go through the consent process and the operation in more detail. Hopefully, so by the time you come to the operation, they're very well informed.
Yeah, Colin, there is another important thing that we do here in the specialist spine unit, and that's outcome questionnaires. So we currently use Amplitude, which is British Spine, British Association of Spine Surgeons, the Spinal Registry, British BSR. We are going to change a little bit to a specific HCA questionnaire, and it's a patient is voluntary, but by patients filling in the outcomes, we know how well we do or how badly we do. We know what works, and other patients can benefit from that. So the patient that's filling in the form doesn't benefit. It's a gift to patients that follow them. It's a pathway. So you can say, you can look at it and say, with discectomies, for example, for prolapsed disc, not everybody gets rid of their leg pain. There's a group of people who still have some persistent leg pain that can take a couple of months. But we can give that data and say, look, here is what we expect from thousands of patients. And that's really important. And we can also find out whether particular procedures we're doing are working and have good evidence for it.
Absolutely, it's a fantastic process. Sorry, Mr. Anwar, if you'd like to add to this kind of patient, discovery process, patient informative process.
I mean, the difficulty is that patients often have a lot of information, a lot of things that they're worried about. And, our job is to try to work out what really is related to what's going on and what is not directly related to the pathology that's going on in the spine. And sometimes you can think that there's a lot of different things that are happening to you, which are actually because of a problem in the spine. But actually, when we look at what's going on in the spine, it doesn't look to be the case. So trying to pick through that is actually really important, understanding what people are experiencing. And that's the only way for us to be able to actually treat people appropriately. Because if you could see some, say, for example, the example of the patient that Colin described earlier, somebody comes in with some neck pain and a bit of pain going down into her index finger and thumb. And you say, well, that's obviously a C5-6 problem. That's you can have some physio, an injection, you can have an operation. But actually, that doesn't worry her that much. The thing that she's really worried about is that her balance has become a little bit dodgy, that she's forgetting things or something like that. Could that be related? Well, could and it couldn't, So understanding where somebody's coming from is really important. And we try to make sure that we do understand what's actually worrying them. Because sometimes it is mainly because of the spinal problem. Sometimes it's not. And that allows us to be able to treat people properly. So I think seeing people multiple times also helps a lot. I don't want to reiterate what people have already said, but the first appointment is an introduction. You get to know people a little bit. You get to know what's going on. Often it's the second appointment that you really get down to the nitty-gritty of what you're going to do.
Fantastic.
Yeah, I agree.
Yeah. It's really interesting. And I wonder, it leads us nicely then onto, I suppose, do you guys have any specific case studies or success stories for any patients with regards to recent spinal surgery techniques? Or
you're asking a bunch of surgeons whether they have any failures. All of our patients, it's a really bizarre group, and Hanny hit the nail on the head. What you don't often understand is the fact that this is a person who's got back pain with some disc degeneration. And you think, well, that's okay, go for some physiotherapy, but their world is being destroyed because their manager can't cope with them. Their only way for mental relief is to go for a 10K run, and they can't do that. So all of those things are really, really important to get into your whole group of when you're treating patients. And that's the art of good medicine, to know your patient, to know the treatment that you're metering out to the patient to get results. So we all like to remember our great results. And one of the best operations is a discectomy. So if somebody has root pain, they have sciatica, you do a decompression, it gets rid of their root pain, their leg pain. They love you for it. Whereas with a spinal fusion, because it takes them quite a bit of time to recover, they often are less, oh, you're fantastic. So it is horses for courses.
Fantastic. And then kind of jumping into the future, I wonder if you have any, I'm sure you have some foresights with regards to what do you foresee as the big next, I suppose, breakthroughs in spinal surgery technologies?
Okay, Hanny, do you want to go first? Do reverse order.
Yeah, so I can't really tell you because you know, this is where all the innovation is happening, right? If we give away all the secrets on this video,
Oh yeah,
then you know, everybody else is going to know what to do. But look, I think actually the next phase of spinal surgery development is actually going to be a data-driven phase. So it's going to be so data and sort of something related to artificial intelligence, which is going to be allow us to be better at working out what the outcome's likely to be for a particular patient, and better at planning exactly how we do an operation to get the best outcome, what's going to give the lowest risk of complication and the lowest risk of revision. I think that that's going to be the thing which is going to make probably the biggest difference in terms of our outcomes in the near future, and that's already coming in. So that would be my thoughts on it. I think that the age of and maybe sort of endoscopy combined with a sort of now we can do bone MRI. Combining that with navigation robotics, you know, you've got a situation where you can use low radiation or no radiation and do minimally or less invasive operations, including complex operations with a high chance of success. So I think that's all coming together now in the next phase. Slightly cryptic answer, I know, but
so I guess from a cellular level, it might be applying what you're seeing in some of the news regions now and LinkedIn with, you know, respective to cancer. So it could be gene therapy, sort of manipulating things in that way to treat degenerative conditions in a less conventional surgical way. We know, for example, they might use, you know, take blood, put it in a centrifuge, and then use those factors which are help against inflammation in other MSK regions in the body. It's maybe not as detailed in the spine, and maybe that could be something that could be explored in the future. And I guess, you know, when we're operating, we do use metal implants and things like that, which some patients could be allergic to. So it could be changing the materials of those so they're you get less artifact with imaging, you get less sensitivity, but still you want to retain the strength that's going to allow under physiological load to withstand all the normal pressures.
So the thing you have to remember is that Winston Churchill said there are two types of people in this world, those who have back pain and those who are going to have back pain. Back pain costs this country 13 billion a year. It is not sexy. It is really common. And back pain is not just for Christmas, it's for life. And this is one of the big breakthroughs goes back to what Hanny was saying. It's going to be about volume medicine. It's going to find out which patients should be referred into to surgeons, which patients should go straight on to physiotherapy, who should have an MRI scan. And it's about value for money. And that's going to come from big data. And what you need to do is you need to educate patients, reassure patients that they're going to hurt themselves if they overdo it, but they won't harm themselves. And then with the information that we build up from our treatment, you can almost pre-program and say, look, you've had your pain now for 6 weeks. we know that hardly anybody is going to get better now. So your best bet is to have a decompression, to have it endoscopically because it's minimally invasive, and your best chance of success is to have a decompression, and you should have it now to optimize everything, not wait. You're not going to be paralyzed. These are the results. And it's almost an algorithm. It is amortizing your back pain. So you're deriving an algorithm based on best possible evidence, and you will just get patients better in a very predictable way. And that's health efficiency. That's cost efficiency. That's where it's all going to come. You won't have a choice. The computer will say, you need a discectomy, and you'll say, I'm a bit worried. And the computer will pat you on the back and go, there, don't be worried. Go see this person. They get great results. That's going to be a massive breakthrough data.
Absolutely. The next couple of years are absolutely, well, the sky is the limit, really, really, for orthopedic surgery in general, not just spinal surgery. So I would just like to say, Mr. Colin Natali, Mr. Ramsey Chammaa, and we have Mr. Hanny Anwar as well, who joined us. Thank you so much for joining us, all three of you guys, for your insights. And if anybody would like to know more about the latest advancements in spinal surgeries, at the clinic that the doctors practice at, you can visit their top doctors profiles on the top doctors website. And once again, the three of you, thank you very, very much for your time.
Thank you.
Thank you so much.
Pleasure.